My name's David Goodier. For those who don't know me, I'm consultant for limb reconstruction and complex trauma at the Royal National Orthopaedic Hospital, and I'm honorary lecturer in sport and exercise medicine at Queen Mary, University of London, and a consultant at TLOC. It falls upon me to talk to you about the knee. Now, this does stand a chance in this audience of attempting to teach my grandmother to suck eggs. You all know about the knee. The knee is a remarkably simple joint. There's some bones. If you put those bones together and stack them like that, they will fall apart. There is no inherent stability in the knee without its soft tissue constraints. The patella sits on the front. It is guided in that little groove in extension by absolutely nothing. It doesn't sit in the little groove until you start to flex your knee. If it's wrongly positioned, it won't go down the little groove. It'll go to the outside and you will suffer a lateral patellar dislocation. This is a bad thing. The reason it stays there are lateral structures, there are medial structures. There are static structures that form ligaments, and there are dynamic structures, the balance of muscles around there. Now, the problem with hypermobility is twofold. The static structures, the ligaments, may be lax. The dynamic structures may be misfiring. And the problem is, all it takes is one relatively minor injury to convert those nicely balanced structures to malfiring, wrongly transmitted impulses to the muscles to upset that balance. So the real problem in hypermobility that I see is patellofemoral joint problems. And that really comprises subluxation, where it doesn't completely come out of joint, but one part lies across the other part, and dislocation. Now, we see that in people without hypermobility in the presence of abnormal anatomy. People who've got a very flat femoral groove, people who haven't got much in the way of a patella, where it's dysplastic in the trochlear or the patella shape is wrong. We see it in people with an elongated patellar tendon, the patellar alta situation, where the patella is faced with a choice of taking that shortcut around the side of the lateral femoral condyle. And for many years, we conceptualized this concept of the patella moving laterally. Well, I put it to you that that's actually the wrong way to think about the knee. The knee is a hinge that sits between the hip and the foot. And all those structures are attached to the pelvis at the top end and the foot at the bottom end. So as Justin pointed out, the foot is there to transmit load. Okay? The knee is critically dependent on the foot position, and the knee is critically dependent on the hip position. We all know that if you're suffering from weak gluteals, we all know that if your ITB is not working properly, your hip will adduct, it will internally rotate on a single leg half squat. And then your patellis tempts to go to the outside. Well, that's fine. Most of us can train out of that. You can do it. If you have problems with the feedback from your hypermobile ligaments, it tips you over the edge. It doesn't take much to put you in that situation where you're going to get lateral patellar subluxation and dislocation. The dynamic stabilizers can be reprogrammed. It's very easy to reprogram them in a person without hypermobility. With hypermobility, that proprioceptive feedback is lost. It takes an awful lot more to reprogram people for balance. And when you send people off to physio and they concentrate around the knee, they're really missing the point. These people have completely destabilized. Often a relatively minor injury will result in complete loss of coordination. They lose their core stability, they lose their gluteal control, they misfire at the knee, and it needs an awful lot of physiotherapy and retraining to deal with this. Sorry, I went into treatment there. I apologize. As I say, there are the dynamic stabilizers that can be reprogrammed, but there are also the static stabilizers. We're becoming increasingly to recognize the medial patellofemoral ligament. The MPFL is one of the stabilizers. It's really condensation of the capsule on the medial side. And if you do get a lateral patellar dislocation, often it can't be reprogrammed without surgery to it. The common surgery to it used to involve translating the focal point of the knee by things like moving the tibial tubercle, doing lateral releases. Actually, you can put a static stabilizer in place by reconstructing the medial patellofemoral ligament these days. And there are very simple kits to do that and simple ways of doing it. We tend to use ligament augmentation if they're hypermobile, with a little tiny bit of tensile ligament augment that will make that better. The other thing you need to know about in terms of the knee is the ACL. If you are hypermobile, you do tend to have knee extension, which is an independent risk factor for ACL rupture. And unfortunately, if you're hypermobile, the objective results are actually less good post-reconstruction. There are many papers out there that point this out. Does that mean you shouldn't do it? Well, no, you should still do ACL reconstruction in people who need it. You just need to be aware that the re-rupture rate is higher, the patient satisfaction rate is lower, and they may need much, much more input, particularly in proprioceptive feedback during their physiotherapy regime. There's a bit of controversy about tissue choice. If your hypermobility is actually due to a significant problem with your collagen and use hamstring reconstruction, it will tend to stretch out a little. So there is some evidence that bone patellar tendon bone constructs actually work better than ligament norming, but that's really a sort of surgical decision and not really part of the decision-making process. But you do need to understand these things before you actually take these patients on. And often you get people who feel unstable, and they often get referred up as query ACL, but they're not. They're people who have had a hyperextension injury in a knee that hyperextends. They may have strained their ACL, and what that's done is it's torn it enough that they've lost their proprioceptive feedback. The ACL is not just a guy rope in the middle of the knee. It is absolutely packed full of nerve endings that give you a lot of proprioceptive feedback. A relatively minor injury will wipe out that proprioceptive feedback, and you will have subjective instability that will take an enormous amount of proprioceptive re-education. And what do these people do? Well, they tend to wear knee braces because it gives them that extra proprioceptive feedback. And what does that do? It cuts down their native proprioception. So when they take the knee brace off, they're even more wobbly. So no knee braces, lots and lots of proprioceptive feedback. And of course, as I said time and time again, in relation to all things knee, the knee is just a hinge in space. What it actually does is most dependent on your core stability, your gluteals, and your foot position. And if Justin had one take-home message, this is mine. The knee, most of the knee problems I see are actually secondary to problems outside the knee, so don't focus on the knee. Thank you.